So the first speaker today, great pleasure in introducing, is Dr. Emily Methangkool, who is the Vice Chair in Quality and Patient Safety at UCLA, and she is MD and she has a master's degree in public health. She is the Vice Chair of the Quality and Safety for the UCLA Department of Anesthesiology and Perioperative Medicine, and is an associate professor in cardiothoracic anesthesiology. She is passionate about patient safety, quality improvement, cardiac anesthesia, and gender equity in medicine, and has written about and spoken on these topics at the national level. She is the current Vice Chair of the ASA Committee on Patient Safety and Education, former Vice Chair of the Women in Cardiothoracic Anesthesia, and she has a special interest group of the Society of the Cardiovascular Anesthesiologists, the communications team of the Anesthesia Patient Safety Foundation. So we have an eminent speaker from Los Angeles. I will ask now the speaker, Emily Methangkool, to take over. Thank you.
Good evening, everyone. My name is Emily Methangkool, and I am an anesthesiologist at the University of California, Los Angeles, where I serve as the Vice Chair of Quality and Patient Safety for the Department of Anesthesiology and Perioperative Medicine. Much of my academic and clinical work has focused on non-operating room anesthesia, and so I am very excited to be able to discuss with you today some of the challenges and opportunities in NORA. I don't have any disclosures that are particularly relevant to this presentation. And in this talk, we will be discussing the evidence on patient safety in non-OR locations, describing some of the factors contributing to challenges to patient safety in these areas, and also exploring opportunities for improvement in the non-OR setting. So what exactly are we talking about here? And I know much of us, or much of you on this webinar here today, have had the immense pleasure of delivering anesthesia outside of the operating room. But I'd like to just show you an example of what these difficulties are. So this is a room that combines two non-OR locations in one. It's an MRI cardiac catheterization laboratory. And as you can imagine, the addition of an MRI machine and the cath lab really introduces many ergonomic and logistical challenges. For example, the patient's head is right in between these two arms of the MRI machine, which you see here in white. The fluoroscopy equipment is right on top of the patient's head. The anesthesia machine is shoved all the way in the back here. What's really not pictured in this image is the fact that the medication dispensing cabinet, or the Pyxis, is on the complete opposite wall to the anesthesia machine. And the computer, where I am supposed to be documenting vital signs, is diagonally opposite to the anesthesia machine. And what that means is that in the course of caring for this patient, I will be expected to walk through all four corners of the room. And if I am busy charting, or if I am busy drawing up a medication, for example, I could be very physically far away from the patient's head. So as you can imagine, this is an extremely challenging place to provide anesthesia. And this challenge is felt acutely by clinicians all the time in NORA locations. This was a great letter to the British Journal of Anesthesia by a colleague from Dartmouth. Her name is Dr. Hetty Schrock. She summarized results from interviews of clinicians providing care in NORA. So a few representative comments are that the mental work is much higher, and that's where the stress comes from. People operating in an environment that they're not 100% comfortable, I think, poses a risk to the patient in general. And having to be mindful of having sort of every piece of equipment and every medication that one could foreseeably need requires more preparation up front. So providing care in these areas is stressful, but how does this actually relate to patient safety? So what's the evidence that NORA locations are inherently more unsafe than the general OR? So first of all, let's define what we mean by NORA. NORA stands for non-operating room anesthetizing location, and basically is a catch-all term that identifies any area where we as anesthesiologists or anesthetists provide care that is outside of the operating room. So NORA can refer to both inpatient locations or hospital-based locations, as well as outpatient locations, such as in a surgery center, in a clinic, in a physician's office, for example, for a dental or cosmetic procedure. The term is also inclusive of many different types of areas and many different types of procedures. For example, in the cardiac catheterization laboratory, you could be doing a spectrum of interventions, from percutaneous interventions to transcatheter valve replacements to arrhythmia ablations. In the GI suite, you could be doing a standard colonoscopy or doing an interventional procedure. In interventional radiology, you could be doing a line replacement, a clot retrieval, or a stent placement. In diagnostic radiology, you could be sedating patients for an MRI. In electroconvulsive therapy, you could basically be inducing general anesthesia without a protected airway for the procedure. Or you could be doing oocyte retrievals in reproductive endocrinology, and these often takes place in physician offices that are far away from other anesthesia locations. We know that the growth of anesthesia services outside of the operating room has grown exponentially over the past couple of years. This was the last good, large-scale epidemiologic comprehensive study of data. It's from the National Anesthesia Clinical Outcomes Registry and basically examined data from 2010 to 2014. And we do have some updated data that I think will be coming out in the next couple of months or so. They found that cases that were done in NORA increased from 28.3% in 2010 to 35.9% in 2014. 8 years later, NORA cases comprise a much higher percentage of total anesthesia cases. And we know this because the demand for anesthesia services in gastroenterology has increased, and the growth of procedures in interventional radiology and in the cardiac cath lab, for example, transcatheter edge-to-edge mitral valve repairs or transcatheter aortic valve replacements, that has also increased exponentially since 2014. So what are some of the characteristics of NORA cases? More cases are more likely to be started after 5 p.m., and this is when you have fewer resources and fewer personnel. They do comprise an increasingly higher percentage of cases, as we discussed, and the patients do tend to be older and sicker. And all of these factors really contribute to adverse events in NORA. So what does the evidence say about patient safety in NORA? And we have two pools of data that we can really look at. One is observed mortality, and this is looking at all anesthesia encounters and all comers. And there's also closed claims data, and these are cases where malpractice claims were brought forward. So when you look at observed mortality data, there was an analysis of over 47,000 pediatric patients from 1998 to 2007, and they found that observed mortality in NORA was almost twice that of the operating room. But there was a subsequent retrospective study of nearly 200,000 cases from 2013 to 2017 that found that the observed mortality in NORA was similar to that of the operating room. Now, again, these are all comers looking at all observed mortality. Now, when you look at the closed claims data, it's a little bit of a different story. Now, again, these are cases where enough severe harm occurred that a malpractice claim was brought forward. In an analysis of closed claims from 1970 to 2001, claims of death were increased in NORA, and similar trends were observed in closed claims analysis from 2006 to 2009 and 2000 to 2012, and all of these were statistically significant. Adverse events are more likely to be reported in NORA compared to the operating room, and in fact, severe adverse events are more likely to occur in NORA compared to the operating room. Analysis of the closed claims data have found that claims in NORA compared to the OR were more likely to be deemed to be due to substandard care. They were more likely to be thought to be preventable by better monitoring, and they were most commonly associated with problems with oxygenation and ventilation. And although GI cases comprise the vast majority of cases that we see in NORA, at least according to the National Anesthesia Clinical Outcomes Registry data, cardiology and radiology cases represent an outsized proportion of malpractice claims. And this may be intuitive because of the less invasive nature of many GI procedures, as well as the fact that there are many healthy patients that are undergoing screening colonoscopies. Whereas if you are coming in for an interventional radiology procedure or a cardiology procedure, you probably have more comorbidities that are leading you to have these procedures. So all of this really begs the question, why NORA? Why do we see so many more complications? Why is it so much more stressful to provide anesthesia care in these areas? So patients coming to these areas may not necessarily be good candidates for open surgery. However, they do happen to be candidates for procedural interventions. Also, we are constantly pushing the envelope with regards to what is being done in these areas. For example, interventional pulmonology is placing endobronchial stents and debulking tumors in mainstem bronchi. And interventional GI is doing what really amounts to surgery. They're doing these per-oral endoscopic myotomies in the GI lab. And these procedures are often short. They're deemed to be minimally invasive when they do, in fact, pose some significant risk. Monitored anesthesia care is a common anesthetic modality that is used in these areas because of the quote short procedures and the quote minimally invasive procedures, but MAC itself may be a factor in contributing to problems with oxygenation and ventilation, as we've seen in the closed claims data. One way to start improving care in these areas is by first identifying what some of the root causes of adverse events in NORA are. One is location. The NORA location may be physically located far away from the main operating room. It could be on a different floor entirely or even in a different building, as I've seen in many hospitals. This makes it very difficult to access additional personnel and equipment in the case of an emergency. Many of these areas were constructed 10 or more years ago when anesthesia services were not as widely needed as they are now. And what we've had to do is really retrofit everything we need to provide anesthesia safely into these very small areas and suboptimal locations. And this in turn makes the ergonomics of providing anesthesia care in these areas very difficult. Often the space that's allocated to anesthesia is not that significant, and you may not have access to all of the things that you need, for example, scavenging or pipeline oxygen. The room is often dark, making it very difficult to see the patient and maybe makes it very difficult to monitor their oxygenation and ventilation. And the patient's head may be physically inaccessible to the anesthesiologist, as we've seen in my example of the cardiac cath lab. We may not have all of the equipment we need. For example, some locations don't even have an anesthesia machine or all of the medications that we are used to having. The procedural team may be more used to taking care of patients under conscious sedation. So they may not be used to working with an anesthesia team or to thinking about anesthetic concerns. And on the anesthesia side, we do not necessarily know the way proceduralists do things either. We aren't necessarily familiar with the medications that they want to give or with the minimally invasive advanced procedures that they are performing. It's also sometimes very hard to tell exactly what they are doing because all of these procedures are minimally invasive. All of this combined creates a lot of distraction. So figuring out where the monitors can go, on which side of the patient the anesthesia machine can go, where the head of the patient, where the head of the bed is, really all of that really distracts from monitoring the patient. And finally, production pressure can be quite significant. A lot of these cases are short, there's a lot of high turnover, there is significant pressure to get in and out of the room quickly, and this can lead to taking shortcuts that lead to inadequate optimization of these patients and inadequate preparation. And all of this combined leads to an adverse event. This is compounded by communication issues. There are so many different team members who are not used to working together, and this compounds the stress and impacts teamwork and clinical care. So a good comment, again, from Dr. Schrock's excellent paper is, I'm always a visitor to that team. There's not a feeling of exclusion, but I'm clearly a visitor down there. So how can you really care for patients in a safe manner when you don't feel like you even belong in that location? We know that communication issues lead to patient harm. So communication issues are common. They occur in up to 30% of all procedural communications as often as every few minutes. And when you look at the ASA closed claims database on communication failures, we found that they've contributed to 43% of claims. They're more common in the outpatient setting, more common in MAT cases. And when they did happen, care was deemed not to be appropriate in those cases, and they were more likely to be paid out. So what are the factors specifically affecting communication and teamwork in NORA? One is that these are ad hoc teams. These are teams that are working together infrequently because many NORA cases are done with proceduralist guided conscious sedation. So they are not used to necessarily working together. And as a result, there can be unfamiliarity on both sides with procedures and personnel. A qualified personnel may not necessarily be available. For example, a nurse may not necessarily be available if you are taking care of a patient in MRI, or if you are doing an oocyte retrieval, there may not be additional personnel to help in cases of an emergency. There is this common thought amongst both proceduralists and anesthesiologists that it's just a MAC and so it's of low risk, but this perception is not necessarily correct, as we've already seen from the closed claims data. And there may also be a lack of defined roles and responsibilities, and this can be really important when there is a crisis or an emergency situation. There is some evidence to suggest that NORA locations may not be as well equipped to handle emergency or unexpected situations as the operating room. For example, if you have a massive hemorrhage that occurs because of a procedural complication that requires large-scale massive transfusion, or if you have the need to perform sternotomy or open surgery in a cath lab or an endoscopy suite, that can be exceedingly difficult. And this is due to limitations from not just the physical location itself, which can be very small and unable to accommodate large teams, but also due to lack of necessary equipment and lack of trained staff. In addition, there may be difficulty intubating. There is some evidence that intubation is more difficult outside of the operating room, and this may be due to inability to manipulate the head of the bed, suboptimal positioning of the provider, and lack of accessibility of the patient's head. While difficult intubation occurs in about 3 to 8% of surgical cases, in ICU intubations, the incidence can be as high as 25%. And while the cause of difficult intubation in the ICU population is certainly multifactorial and can be related to both patient and comorbidity, I think there are similar themes between the ICU and the NORA in the fact that head position and location have been cited to be significant factors in contributing to difficult intubation. So this all brings us to the question of what can we do to improve patient safety in non-operating room anesthetizing locations. And when we look at the root causes of adverse events, these are also opportunities for improvement. For example, making sure that the locations of NORA are grouped closer together, altering the configuration of the rooms to make them more ergonomic, working on team dynamics, all of this can help us improve patient care. So what does the Anesthesia Patient Safety Foundation have to say about NORA? So every year, the Anesthesia Patient Safety Foundation holds an annual conference on a patient safety topic. This is not your usual medical conference. Rather, this is a consensus conference intended to bring together experts in the field to come together to make decisions and recommendations about what to do next on an urgent patient safety priority. As a result, the conference is kept rather small, only about 130 attendees, and attendees are broken up into groups to allow for discussion and consensus building. Our most recent conference was on NORA, and it was held in September. As a result of this conference, we were able to create recommendations on how to improve patient safety in NORA, and our meeting report was just published last week in Anesthesia and Analgesia. There are 42 consensus recommendations, so we don't really have the time within this webinar to go over all of them here, but I will provide a few highlights. And so in terms of facility and equipment, anesthesiology personnel should participate in planning, construction, expansion, or remodeling of NORA locations to ensure that patient safety and anesthetic needs are met. And this is really to address the location and ergonomic concerns of NORA. Anesthesiology personnel should also encourage facility design teams to group NORA suites together near the OR or the PACU to facilitate rapid access to additional personnel and equipment when needed. You will notice as you read through those recommendations that they in general require that the NORA locations have similar standards of care to the operating room. And I think this is really an important theme. Many of the safety events that we have seen are because these locations are not optimized in the same way that an OR is for an emergency. As a result, the APSF recommendations ask that these areas be equipped and staffed similarly to the operating room with dedicated personnel and standardized preoperative and postoperative procedures. I will also mention here that as much as it would be ideal to redesign the NORA space or be able to be there at the planning and construction phases of when a new NORA area is being built, many of the areas that we are forced to work in have been retrofitted for anesthesia care, and that in itself is not easily modifiable. Unfortunately, we do have to work with the spaces that we have been given, but there are things like communication, teamwork, and collaboration that are a little bit easier to address and can help improve patient safety. So what are a few of the ways that we can utilize to mitigate risk in NORA? So we can do targeted interventions to improve both situational awareness and psychological safety in these areas. One is making sure that we have really good pre-procedure optimization. So we have to establish a process by which patients with significant comorbidities are forwarded to the anesthesia team for evaluation well ahead of their scheduled procedure, or even forwarded to a preoperative clinic well ahead of time so plans can be made. Standardizing care through pathways and protocols can create a shared mental model for procedure-specific steps and needs and basically ease that burden of knowledge. Having an established liaison between anesthesia and procedural services can be very, very helpful. So for example, having a director of non-operating room anesthesia can be helpful in providing a person who is the liaison for any quality or safety concerns that can be approached from both the procedural side as well as the anesthesia side. Holding interdisciplinary conferences amongst the proceduralists, nurses, technicians, and anesthesiologists is necessary to help review previous cases where things could have gone better, as well as upcoming cases where patient comorbidity or procedure could be a concern. Having smaller dedicated teams who work together often in NORA can help improve team familiarity, and also having shared communal spaces where members of different teams can interact in a social setting outside of the procedural or work area can also help decrease feelings of being a stranger or discomfort in the area. So perhaps having a breakfast room or a shared social room can be helpful. And finally, doing team training and in situ simulations in the actual physical space of the procedure area can help determine pain points and areas for intervention. There are two other general areas of opportunity for intervention that I would also like to mention. If we think back on the data that was presented, many of the adverse events in NORA stem from problems with oxygenation and ventilation, which are intimately tied back to how we manage the airway and how we deliver sedation. So there are opportunities for improvement here. So two things that we have tried, that I personally have tried, are high flow nasal cannula and nasal positive airway pressure. So high flow nasal oxygen really improves the efficiency of ventilation and enhances oxygen delivery by washing out the dead space in the nasopharynx, as well as by increasing PEEP. And I found it to be quite effective for patients, for example, who have end-stage lung disease and they're on the lung transplant list and they're coming in for a minor procedure in interventional radiology or in GI. And you don't necessarily want to intubate them because you know that you won't be able to extubate them. But they also have very scant pulmonary reserve. So titrated anesthetic techniques with the use of dexmedetomidine, for example, with high flow nasal cannula has been really, really effective in my experience. Another device that we have tried at my institution is nasal positive airway pressure devices, especially for endoscopies and especially in the high BMI patients. This has allowed us to help maintain a patient's airway through the sedation. Other opportunities include new methods of delivering anesthesia. One particularly exciting prospect is remimazolam, which was approved just a few years ago in the US, and I believe is also approved in Europe and in many places in Asia. Remimazolam is an ultra-short-acting benzodiazepine that allows rapid titration and rapid recovery. It basically has a carboxylic ester that allows for rapid metabolism by nonspecific esterases. Anecdotally, there has been very good results in using it for sedation in IR and in GI, and there are studies underway to examine its sedative efficacy specifically in NORA. Another exciting prospect is physiological closed-loop controlled infusions. And I know that target controlled infusions has been available for some time in Europe, although it's not yet been approved in the United States. Physiological closed-loop infusion systems use set physiological goals, for example, a BIS number, to titrate the sedative. It requires a computer-controlled algorithm, a sedation delivery device, and an effect monitor to provide feedback to the controller. While it's not in wide use now, it can be particularly applicable to NORA settings in the future, given all of the difficulties in monitoring anesthesia and delivering anesthesia in NORA. And while artificial intelligence is all the rage nowadays, I do think in the future, AI will play a much bigger role in how we monitor and care for our patients and can be particularly helpful in NORA. I will also mention here that if you are interested in NORA, please join the NORA Society. It's a small group, a community of practice of dedicated leaders in NORA. We meet once a month on Zoom to discuss various topics that are of interest in NORA, mostly with the purpose of learning from one another. So it's a really, really informal group of discussions. We've had cases presented where people present a difficult case and ask for opinions on how it should have been done. We've had topics and discussions about things like positioning injuries, doing simulations in NORA, and it's really just a great way to get to know what other people are doing in NORA, and also to know that the problems that we are encountering are not singular and do tend to be universal. So how do we tackle problems with patient safety in NORA? I do think that it comes with recognizing the risk of patient harm in NORA, making sure that to the extent that we can, optimizing the ergonomics and the location, providing good team building and team training, making sure that we have standardized procedures and policies, and also providing or exploring new techniques for airway and sedation management. Thank you very much, and I look forward to any questions.
Thank you for that very clear, excellent talk, Dr. Methangkool. That was so very nice.